disease or the disease of other organs, but having the similar symptoms. And another thing is that I think we are lack of the comprehensive training of BGBI, including IBS, in the training for the doctors in university and also after for the postgraduate, especially for the GI doctor. There is no curriculum until now, only focusing on BGBI. Another thing is that sometimes when we're doing the clinical practice, we forget about psychology factors. But in fact, psychology factors is very important. So screening for anxiety or depression in the patients and trying to manage and optimize treatment for the patient is also very important. So that is why when we apply Rule 4 for the study, it is very clear. But for the clinical practice, sometimes you will see that it is not easy, like applying Rule 4 in clinical practice. How about the viewpoints and practice of the doctors in reality? So you can see only 30% of the primary care of the GP understand about Rule 4. And 60% of the doctors never use Rule 4 in clinical practice. So for GI doctor, Rule 4 is something like we say that standard when we thought about the criteria of diagnosis of IBS, but in fact it is uncommon for the GP to diagnose. And then, as I mentioned, Rule 4, very famous, popular, standardized in research, in clinical practice. Not so many doctors really apply it. Most doctors will use their own experience, their personal experience. And what they base on the clinical symptoms. And they are based on no organic meaning, like they can indicate endoscopy on the stool sample and it's normal, and then the symptoms like IBS. So then the IBS diagnosis was established, not really follow the Rule 4, especially the duration of time. There are many things that we have to differentiate with IBS, especially I think the most important one will be IBD and cancer, because they have the complications very differently. So when we summarize the data, misdiagnose the IBD can be misdiagnosed. Some intolerance like lactose or fructose intolerance or SIBO is also have the very similar symptoms. So how about IBD? You know that sometimes it is very difficult to diagnose IBD at the first time. Why? Because sometimes it happens after a diarrhea, and sometimes the symptom is very similar to IBS, and there is a prevalence like 10% of the IBD patients. They have the previous diagnosis of IBS before they have the confirmed diagnosis of IBD, and a prevalence of them even received the IBS treatment before they were diagnosed IBD, and this is mentioned in many studies in the literature review. The second thing that I have mentioned is colorectal cancer. Why? Because sometimes, for example, in Vietnam, the cost of endoscopy is really cheap. So many doctors can indicate colonoscopy very quite easily and feasible for the patients, especially about the cost or effectiveness for the patient. But in many countries, they have to wait for a long time. The cost is very high. So that is why they only indicate the colonoscopy when the patients have alarm symptoms or the age is more than 45. So that is why sometimes the colorectal cancer can be missed or can be delayed because it was misdiagnosed with IBS. Another problem that is causing challenges for doctors with IBS is the overlapping. We don't like overlapping. Why? Because the patient will have many symptoms, both the upper and the lower GI symptoms. Yesterday we have heard a lot about FD, and we find that it's really difficult. Sometimes it's difficult to diagnose between FD and osteoporosis. And we saw that there is overlapping symptoms between FD and IBS. And the problem is that for the overlapping side, the severity of the symptoms seems worse. And then the patient seems to have more anxiety and more depression. So that is why it is also something we feel very difficult when we approach of IBS. According to the different consensus, there are many similarities and there is also a little differences. So this is the BSG from the British Society. You can see that if the patient is having the symptoms suspected of IBS and no alarm symptoms, okay, it's very good. But you have to take the medical history and the physical exam very carefully. Why? Because you have to indicate the exploration test to exclude other diseases. And colonoscopy will be indicated when the patient having the alarm symptoms are over 50. And then you also can do another things like the inflammation biomarkers, or you can do the fecal test, the stool, to exclude other kinds of disease. It is also very similar in ACG. They focus a lot in the history taking, in the clinical symptoms surveys, in the physical exam, and also they try to minimize the unnecessary diagnostic test. How about the ASEAN? We have the second ASEAN consensus on IBS in 2019, and you can see here that you can see the role of, besides other tests that have been mentioned in the previous Western consensus, you can see that the Asian experts also focus on the fecal test, especially the parasite and the CDC. Why? Because our Asian population, we have a high prevalence of parasites, and we have like the parasites and we have the infectious colitis, which is very common. So that is why this is one of the causes we have to exclude. The Seoul consensus in 2025 is still very similar, but they focusing in another point, that is CRT screening. Why? Because in Asian population, the colorectal cancer is very common, and the more we have observed more and more patients in younger onset, so that is why, besides the alarm symptoms, besides the age, we also have to check very carefully about any other risk factors to indicate the colonoscopy soon earlier for the patients. Very similar in India and in Korean guidelines. So this is a table to summarize the difference between the Western and the Asian guideline until now about how to approach the IBS. We can see that for the Western country, the additional exploration is needed when the patient having alarm symptoms. But you can see that in the Asian, there is several points different. The first thing is that colorectal cancer screening can be performed in earlier age and based on the family history. So it is very important one to remember. And the second thing is that the stool sample is also mentioned in many Asian guidelines because we have the higher prevalence of parasites and infectious colitis. So this is also very important. For the Western, they mention a lot about differentiate or with celiac disease. But in Asian, celiac, especially in Vietnam, celiac is not common, very rare. So that is why celiac is not a priority to screen. Yeah, so that is something that you can have a general overview about what is the difference in the world. So this is again the differential diagnosis. So I just want to emphasize that between IBS and IBD sometimes difficult, but what are we having in clinical practice? So when you are not sure, please remember to do the inflammation biomarker, and please remember to do the fecal granule testing if you have it, because it is very useful. If you cannot indicate the colonoscopy for the patient. So for the colonoscopy, sometimes it's not easy to diagnose IBD, even the endoscopist suspected it. Why? Because you need the support from the pathology, and you need to do the biopsy as a protocol. So as the protocol now, you have to take like at least 2 specimens in each segment, and you have to take 5 specimens, especially including the ileum and also the rectal. So that is why sometimes in clinical practice, especially in Vietnam when we cover the insurance for the patient, it's very difficult to do. And you have to separate the biopsy samples. And then the pathologist must have the experience in IBD diagnosis. So this is one challenge. But even that this is challenging, but in the case you cannot differentiate, it is very important to remember doing the biopsy protocol in the appropriate way. Macroscopic colitis. Macroscopic colitis sometimes is very similar to IBS-E because they have watery diarrhea. But the important thing is that the endoscopy of macroscopic colitis is normal. So sometimes it is more challenging than IBD to diagnose macroscopic colitis. So when you suspect, when the patient doesn't respond very well, you can do the biopsy and ask your experienced pathologist to help when you really suspect of macroscopic colitis. For the infectious colitis, just remember, we are in the region that have the burden of infectious colitis. So if you see the lesions, very easy, try to do the stool sample for the patient and try to check about the inflammation biomarker for the patient. Celiac is not really a problem in Vietnam now. We have some case reports about celiac, but for celiac, you will need to check the antibody for the patient. And for other function disorders, remember that if your IBS patient have the pelvic floor disorders, remember that we are studying about motility tests, so remember to perform or indicate the HRAM for the patient. I'm sure that this slide has been mentioned in previous lecture. It is also very important to phenotype the subtypes of the IBS, IBS-D, IBS-C, IBS-M, or unidentified. And please remember that why we need to phenotype IBS, because optimize the treatment will be different. Besides abdominal pain, of course, the treatment for the diarrhea patients with the constipation predominant symptoms will be totally different. And another thing to remember is that sometimes during the progression of IBS, they can change the subtypes. For example, sometimes the patient coming to you with the diarrhea predominant, and after the treatment, several months later, they come but with another symptoms, maybe even constipation. So you have to optimize based on the subtypes and on the predominant symptoms of the patient. So I want to, in 15 minutes, I want to summarize some important points. First, even that role 4 is the diagnostic criteria for IBS till now, but somehow in clinical practice, the using of role 4 is not so common. So it is very important that we understand clearly about role 4 criteria and try to use it as much as possible. The second thing is that sometimes diagnose that IBS is not easy. If you only base on your experience about the symptoms of the patient and doing colonoscopy, okay, it can be easy, but it is very easy also to misdiagnose with other types of disease, especially IBD and colorectal cancer. So please be very careful and remind in your mindset that there are still a lot of other kinds of diseases that can be misdiagnosed. And the third one is that even that the approach of IBS diagnosis in Western and Asian share many similarities, but also having some differences that requires the local context and based on the local resources. However, both every consensus or every guideline emphasize that we have, when we suspect, we have to do the necessary exploration test, and it is very important to phenotype the subtypes of IBS to optimize the treatment. So thank you for your attention.